This episode was graciously sponsored by Illume Fertility and Gay Parents-to-Be. Illume Fertility is a wonderful clinic that has a wide range of services for everyone. They have a fantastic lab, world-renowned doctors, holistic services, and support services that will provide everything that you need to have the family of your dreams. So set up an appointment and get your tailored plan so that you can see how Illume Fertility can help you build the family that you want. illumefertility.com. So by now, you probably know about my book, Building Your Family, The Complete Guide to Donor Conception. I wrote this book with Dr. Mark Leonderis because there were so many questions that patients had asked us over the years, and we wanted to give that information to more people on a grander scale. Since we've published this book, lots of people have reached out to us with lots of questions. And so we decided today to put together the top 10 most frequently asked questions and answer them for you on this podcast. Now, I have lots of other information on this podcast about all sorts of issues that are also in the book, but today we're going to answer these top 10 questions because we know they're important to you. So I hope that you enjoy, and please subscribe because that's how we keep going. Welcome to Building Your Family. This is a podcast about donor conception, surrogacy, and all the ways the modern family is built. I'm your host. My name is Lisa Schumann. I'm an author, a researcher, a therapist, and I am passionate about helping people find a better path to parenthood. And today on this podcast, I'm very excited to introduce you again to Dr. Mark Leonderis, who's a friend, colleague, and my co-author on our book, Building Your Family, The Complete Guide to Donor Conception. And today we're coming to you because we've had so many questions since we published our book. And I thought that perhaps if we answer the 5 most frequently asked questions for each one of us, that would help you a lot in your journey. And I certainly hope it does. And of course, you can reach out to us anytime. But for today, we're going to share with you some of these tips that you can use and can be very beneficial to you. So thank you for joining, Dr. Leonderis.
Hi, Lisa. I'm so happy to be here. And I love top 10 lists, so I'm all in.
Okay. Do you want to share with the audience before we start a little bit about you and your thoughts about this book?
You know, about me, I'm kind of almost at 30 years in reproductive medicine. It's like amazing how much the field has changed. I'm a board certified reproductive endocrinologist. I also, I'm the founder at Illume Fertility, founded Gay Parents-to-Be, partner with Gays with Kids, and I have a husband and 2 kids trying donation and surrogacy. I take care of everybody. The way I think of the rainbow flag, it means everybody's welcome. I'm really happy that our practice is one of the few practices that is a healthcare equality leader. And I'm so thrilled that you asked me to participate in writing this book. I recently just spoke to some other professionals, and somebody said, I'd like to buy 100 books to give to my patients. It's gotten nice reviews. It is truly, something from the heart that comes from our experience in taking care of patients. So I encourage everybody to take a peek at it and take a read of it. And, for myself, I'm just passionate about trying to guide people with a combination of like heart and science on their family building journey. And I'm just excited to be partnering with you on that and a lot of other things.
That's great. Well, thank you so much. So we're going to talk about these 5 tips, and I'm going to start with Dr. Leonderis. The first question is, can you please explain why IUI seems so difficult for a lot of families to be, whether you're single or a lesbian couple or a heterosexual couple using IUI? People feel like it's so difficult to get started, and why is it that the sperm can't just be directed straight at the egg and it would be so much easier? Why does it seem so confusing and complicated?
Well, first of all, like IUI stands for intrauterine insemination. So, when people have intercourse, the sperm ends up in the vagina and has to travel through the cervix, which is kind of this gateway to the castle. And then it goes through the uterus, which is about another 6 centimeters or 3 inches long. And then it's got another 4 inches to go to get to the where the egg is released at the end of the fallopian tube. When we do IUI, we're putting the sperm at the top of the uterus. So we've cut the path in half. But, the reality is that why is IUI so difficult? Well, there's making sure your fallopian tubes are healthy and open, making sure your uterus is healthy and open. There's choosing the sperm source, whether that be your partner or whether that be donor sperm, there's oftentimes the need, depending on who you are, for legal or social work consultation to get ready. So you've done all this work, but we have to remember that humans actually aren't that fertile. Even a 25-year-old with optimal fertility might get pregnant 25% of the time per month, right? So then as we all kind of age, and I'm sure we're going to take some questions about eggs a little bit later, egg quality goes down. But when we have a situation of somebody who's attempting with IUI, yes, we're trying to optimize everything. But even in optimal conditions, the sperm and egg have to meet each other. And then the egg has to be reproductively competent. The sperm has to be reproductively competent. And then from there, the embryo has to travel all the way down to the uterus. So I always like to say that, we are a really successful species on the planet, but it's mostly because we live a long time and we're smart. But we certainly don't make a lot of babies, right? When we do IUI, we put sperm at the top of the uterus, and you cannot direct at the top of the uterus which direction the sperm goes. So let's say we know somebody's ovulating from the right side. You can't do that. It just goes in, and half the specimen goes right and half the specimen goes left. We're putting the specimen at the top of the uterus. We can't squirt it into the fallopian tube. So the sperm have to kind of go through this teeny little keyhole opening and then travel their 4 to 5 centimeters out to the end of the fallopian tube. And I think people think of the fallopian tube as a pipe. It's not a pipe. It's a whole bunch of little kind of glands pressing into the sperm. A lot of them get stuck in mucus and so on and so on. So probably like very few sperm actually make it all the way to egg. We think it takes hundreds of thousands of sperm, though, to fertilize one egg. I know everybody knows that only one sperm actually fertilizes the egg, but the egg comes out surrounded by a jelly mass. Hundreds of sperm kind of start getting at that jelly mass, trying to be the first one there, right? And then once they get to the shell of the egg, the sperm actually have a mechanism to kind of like break through the shell of the egg by cross-linking proteins. And then there might be 2 or 3 like almost there at the right time, and then one has to merge with the membrane of the egg. That then generates kind of almost like a force field. So no other sperm can get in. So it deposits its chromosomes. Now, that doesn't mean somebody's going to have a baby. It just means the sperm made it in there. Even in the IVF laboratory, when we open the incubator the next day, we see that only 80% of eggs fertilize. So if you only release one egg, 80% of the time, even though the sperm made it, it didn't fertilize the egg. And then that embryo, early zygote, has to divide. And, you go from 1 cell to 2 cells to 4 cells to 8 cells. Then you go to 16 to 32. And then basically there's a moment in time where you've got like the center of the embryo that's going to make the baby. And then you've got the placental cells, which are going to complete implantation. And it kind of looks like a daisy where the center of the embryo is the part that makes the fetus, and then the petals on the outside. So that blastocyst develops in the fallopian tube, and then it has to make it into the uterus. I know a lot of people out there know about ectopic pregnancy, but not every embryo even makes it into the uterus. And we know from the laboratory, especially when we grow embryos out, if I start with 10 fertilized eggs, I might only get 5 blastocysts, right? And then if I have 5 blastocysts, even in the best situation, like we've got like 70% of those are normal. So in IUI, where we typically are only ovulating maybe 2 or 3 eggs, if you do the math, there's a pretty good chance that a non-viable embryo never arrives in the uterus. So getting pregnant by IUI or natural, methods is difficult. And I think we always have to remember that the people who say, "Oh, I got pregnant my first time," that might not have been the first time they had sex, right?
Yes, that's right. Yes.
Right? My world is all around people who are struggling to succeed from all different ways. But remember, 1 out of 6 people suffer from fertility challenges. That's just about 16, 17% of people. So, we want to acknowledge the fact that while you might not get pregnant, you just have to understand it's about multiple times at bat. And if everything else looks good, cumulative pregnancy rates are going to be normalized for your age group, right? So if you're 25 to 30, you're talking about cumulative pregnancy rates after 3 to 4 rounds, upwards of 60, 70%. If you're over 35, it's going to be significantly lower. And that's why people over 35 sometimes choose different methods. It's a long answer to your question, but basically, when you do IUI, the sperm still have a lot of work to do. And since the egg is kind of the machinery that
Mhm.
leads to the creation of the embryo, that embryo has to be normal. So there's a lot of things that have to happen perfectly. Everybody listening to this was really a perfect sperm and egg and embryo because we existed, but a lot of fertilizations just don't go on.
Well, that's fantastic. That's such great information, Dr. Landers. We really appreciate that. Just as an aside, so this whole idea about everything has to be perfect, I think is really helpful, particularly for a lot of the lesbian patients that we see who want to do home insemination, and that can be fine. But I would imagine that it's really helpful for them to keep this in the back of their mind because we don't know if their tubes are blocked. We don't know what's going on in there. And so, what would you recommend, just as an aside? This is not on my question list. What would you recommend to people who are trying to conceive at home with a sperm kit and are unable to? How many times at bat do you think they should give it?
Remember, there's different even kinds of home insemination. There's like, let's just put the sperm in the vagina, let's put the sperm in a cup. And then some people are even doing an insemination. Prior to putting in all that effort and finding the sperm source and doing your legal agreements, you do want to make sure you've had a reproductive assessment. And often your OBGYN can do that. What are your fertility numbers? Are your fallopian tubes open? Does your uterus look normal? Because you can spend months of trying only to later find out you didn't really have a fair chance. So
Hmm.
getting that set up and then understanding that if everything's ideal, home insemination, intrauterine insemination should be nearly the same as in the office, with the caveat that I have andrologists here who are trained to prep the sperm and get everything ready to go through. And you're doing this at home and you just never done this before. So I think somewhere around 3 to 4 tries of home insemination
Hmm.
is kind of max out. The data on same sex female couples is that there's an incremental increase of pregnancy rates upwards of 8 or 9 times, different than infertility patients.
Hmm.
So we need to think about them differently. But that's once again with the caveat that we've gotten evaluated for pregnancy and are prepared for pregnancy, done everything like, taken our prenatal vitamins, optimized our health factors, and thought about our lifestyle choices.
So it's important to know that all those pieces need to be in place in order to try to get pregnant, because if any of them are not, then you're kind of shooting in the dark. You don't know what's going on.
I mean, I tend to think of it like an orchestra, right? If you go to the orchestra and the percussion section isn't working very well, the music's not going to sound well. There's just so many things that have to happen.
It's true. It's a great metaphor. I really appreciate that. Okay, terrific. So, number two question we get a lot is, can I exercise after I home inseminate, IUI, IVF, any of it? Am I able to exercise afterwards?
Yes, please.
Hmm.
So we also have to put that into perspective because people have been getting pregnant for 150,000 years, not even knowing that they're pregnant, right?
Hmm.
So
Hmm.
prior to early pregnancy tests. Obviously, there's a lot of pressure on the process. So the data for insemination, right, where we're putting sperm in the uterus, fallopian tubes float, you can probably do whatever you want. I think it's really important for people to remember that the female pelvis is bony walls. The uterus is cushioned by your bowels, your bladder, small bowel, and it's in the center of this like protective area. You can probably move all you want. Your uterus is really protected from pretty much everything you can do. So in general, what I say is do whatever you want, but be reasonable. Don't exercise to exhaustion. Don't exercise to dehydration. Don't decide you're going to climb a 14,000-foot mountain or like
Hmm.
run a marathon because if it doesn't work, you're going to wonder if that did harm. You're going to wonder if
Yeah.
that did harm. So
Yes.
your head has to be in the game. But moderate exercise, if you're a regular exerciser, you can certainly exercise after IUI. After we do an embryo transfer, we usually tell people to like just do things that make you happy for a couple days. The embryo has to stick, and that probably happens within an hour. And then it has work to do to get burrow underneath the endometrial lining. And that's an active process, right? But once again, it's a really protected environment. And they did the study back in 2014 where women were at bed rest compared to women who were not at bed rest. And the women who were not at bed rest did better. As humans, we don't typically lay down in bed for 2 days. Like that doesn't even make any sense. And there's actually modern incubators, and they've done trials about actually having a little bit of motion in the incubator to help the embryos, right? So I usually say it's take a couple days to take care of yourself, self-nurture, do things that make you happy, and then go back to normal activity. I know that our nurses are like, well, don't overdo it, right? And it's this kind of back and forth. So let's say light normal activity till your pregnancy test is not unreasonable. But I know for a lot of people, their exercise is their stress relief.
Yes.
And that's another part of this process. So that may cause harm. I usually say stress affects every aspect of our being. So you want to be in a good place. So, if you're somebody who normally runs, 3 to 5 miles, every other day, and you had an embryo transfer, there's no data that there's any harm in going back to that a few days after your embryo. I always get questions about going to the gym. I'm like, what do you do at the gym? And most people are not killing it at the gym, and that's fine. Yeah. So yes, exercise, please. American College of OBGYN changed their guidelines many years ago. They said you can exercise all through pregnancy, and it's good for your pregnancy, and actually it's good for labor and delivery. And so that being said, that movement of our bodies is just so important, especially in our modern world where we might sit down for 8 hours a day.
Yes, yes. Okay, terrific. That's great advice. The third question is, how can people decide if they should use a fresh or frozen egg cycle when they're using a donor?
Yeah, so that is a question I get all the time, and it's a question we talk about all the time. And there's different perspectives on this. So let's break down. The human egg is one cell, and when the embryologists, the high-tech dream makers in the lab go to freeze it, it's actually in the middle of a cell division. And they have a very exact process to freeze it that they use for all the eggs, all the same process, to take something that's a single cell and stop it in time when it's in the middle of a cell division going at 150 miles an hour, right? So that itself is very complicated. So when you purchase frozen eggs, you have to appreciate that you're going to lose about 20% at the warming. And then you're going to be on a nutrition curve that not every egg that survives, fresh or frozen, fertilizes, makes a blastocyst, and has an embryo that has good reproductive competence. So when I talk to people choosing fresh and frozen eggs, one of the questions I have is, how many children do you want to have? Because when you get a batch of frozen eggs, whether it's 6, 7, or 8, it's unlikely you're going to get more than 2 good quality embryos, but you may actually only have 1. So you're going to get 1 chance, and you're not going to get an opportunity if you don't get pregnant to get a second chance, or you're not going to get an opportunity to have a sibling.
Yes.
So if people come to me and they want to use frozen eggs and they want to have 2 kids, I'm telling them they should get 2 lots of eggs. And this is where it's an interesting thing that's happened in our field. 2 lots of eggs, you're approaching a cost of $25,000 to $30,000 now, and that's basically the cost of a fresh donor cycle with compensation of the donor. So the cost starts to get kind of equivalent if you're looking at 2 lots of eggs. So fresh versus frozen eggs comes down to your family building goals, understanding that attrition rate, and thinking about your financial capability to go through the process, right? So, I have a lot of intended father couples that want to split their sperm, right? And they're thinking about using frozen eggs, and I tell them to get 3 lots of eggs. And in this situation, sometimes their insurance company is pushing them towards using frozen eggs for accessibility reasons and so on. So, that's kind of how we manage that. They need more like 18 to 21 eggs. And I think, we talk about this in the book as well. But, one of the challenges with frozen eggs is the ability to meet your donor, the ability for a donor to be identity release. A lot of frozen eggs out there, these young women were not counseled, do not have a release for future context. You might not ever have that information for your child to be. The reality is maybe you're going to be able to find that person via 23andMe, and that's why anonymity doesn't exist anymore. But rather than looking for somebody 15 years in the future, like it's better just to like have permission to contact them or have
Yes.
actually met them. So I
Yes.
think one of the things versus frozen versus fresh eggs is if you want to take advantage of the knowledge to have in your back pocket if your child wants to know more, you have a better opportunity to do that if you use fresh eggs versus a frozen egg pool, right? And because currently, a lot of the frozen egg banks do not have identity release donors or even an opportunity to be known. I think that's going to change over time. And we can take this conversation further, as we talk about, sperm sources, right? Thinking about identity release sperm sources as well is probably important to the child. But I got a little off topic. But in general, once you get survival and once you have a fertilized embryo, whether it be fresh or frozen, they do about the same, right? According to the Society for Assisted Reproductive Technologies, still, most recent report in 2022, live birth rates for fresh eggs are still a little bit better than frozen eggs, right? There's a lot of pros and cons because frozen eggs are kind of available. You go through the profile, you pick them, you can proceed. Versus finding a donor can sometimes take months, and then that donor needs to be stimulated, and then you have to then make embryos and then go to embryo transfer. So the time difference is dramatic.
Yes, yes, absolutely. And just to highlight something that you just said, for all of you out there who are not familiar with this yet, what Dr. Landeros is also sharing is that when you have frozen eggs, you may only get, let's say 6 in a lot, but you might have a fresh donor cycle that could make 20 eggs or more, right? So we're really talking about 2 or maybe 3 frozen egg cycles to compare to 1 fresh cycle. So there's really quite a difference. So I think it's worthwhile thinking about that. Okay, so number 4, Dr. Landeris, there's a lot of questions now about PGT. It was kind of looked at as kind of the golden rule. Everybody needs to do it. And now I know there's a lot of questions around it. What are you advising your patients these days?
So pre-implantation genetic testing of embryos, right? We can do pre-implantation genetic testing of embryos for aneuploidy, which checks the chromosome count. There's also different types of pre-implantation genetic testing for structural defects or recessive genes that cause disease. But in the context of should I test my embryos for chromosome count, that's called PGTA. And there are real indications for PGTA. And in general, we do clearly understand and know that as women age, we can have a beautiful embryo that's either is missing or has an extra chromosome. And that embryo has a very low, if not zero, chance for making a healthy human if the biopsy sample is truly representative of the inner part of the daisy. Remember, we talked about the daisy before. So the petals of the daisy are the biopsy, and the inner part of the daisy is the fetus. So there are people who have transferred embryos that have been called abnormal, that have made babies, very low percentage. And there are embryos that we transfer that are chromosomally normal that don't even generate a pregnancy. I think we have to be careful about, saying that this is something that's going to guarantee success. It's also something that I always hesitate to say, like when somebody says, well, you can guarantee my baby's going to be healthy. No, I can't, because it's just checking for chromosome count. It's not looking for birth defects or autism or development delay or anything like that, right? So there's limits to it. But it is true when you look at the national statistics across the board that for women who are 35 plus, if they transfer PGTA normal embryo, their live birth rates basically approach 50 to 60%, where without that, they drop down to even as low as less than 5% in the oldest age group. So, but not everybody has the capability to do that. So should you do PGTA? It really depends on your conversation with your doctor, your biological age, your reproductive age, and understanding that not every embryo gets you a result. So you might test 4 embryos and get results on 3, and maybe 1 is normal One is what we call a maybe. So they're unwilling to say whether it's normal or abnormal, and one is abnormal. And that can be frustrating for patients. I mean, I come from a time where we
Yes,
used to just transfer embryos and hope for the best.
me
Uh,
too.
the power
Yeah.
of PGTA is it's taken us down this pathway of single embryo transfer, being confident that we're not generating, twins and triplets, which I know a lot of people love those, but they are higher risk pregnancies for the person carrying the pregnancy as well as the babies. So I think it's a very complicated answer. Should you do PGTA? I think that if you're over 38 and you're making embryos, PGTA is going to allow you to kind of examine that pool and give you the best chance for success per embryo transfer. If you're less than 35 and you have otherwise good fertility numbers, it's likely not necessary. But you have
Hmm.
to understand that if you do an embryo transfer, right, just like everybody who's always done an embryo transfer the past 40 years, anybody has ever been pregnant, we're going to wait till we're kind of out of the first trimester and the other testing needs to be done before we're going to basically be celebrating that everything's okay. And that is important. And that rule or that guidance also applies to people who do PGTA, because you can still have miscarriages even with a chromosomally normal embryo. We know that in the larger obstetrical population that 50% of miscarriages are chromosomally normal embryos. So just being chromosomally normal does not mean you're going to go on and make an ongoing pregnancy. So there are folks that think PGTA is going to be trended out. There are practices that do a lot of it and recommend it for everybody. So I think it's something to talk about with your provider, as well as think about where your heart lies.
So, in other words, when it comes to donor conception, if you're using a donor from a bank, right, not a known donor who's also maybe 35, but a donor who's 25, then it's less important than somebody who's older.
Absolutely. And there's a 1% to 2% chance of harming an otherwise normal embryo. And there's also a chance that you did this biopsy, you don't get a result. So you've kind of spent thousands of dollars. And if 70 to 80% of embryos from younger donors in their 20s are normal, you might have just had to do another transfer by not doing PG if you did not do PGTA versus,
If
getting
you
all this extra information that is not 100% reliable.
Yeah. It's so complicated now. When I did IVF, they transferred 3 embryos at a time, and they were day 3 embryos, and that was all you could do. So it's a very different world that we're living
Yes,
in, even having
very
this
different role.
conversation, right?
And there's different expectations, right?
Yes.
When you
Yeah.
did IVF, we were happy to have a 20% pregnancy rate.
Yeah. Yeah.
Right?
Yeah.
Now we're pushing the limits upwards of 60, 70% live birth rates in the
It's
best
incredible.
patients. Yeah.
It's incredible. Right. Okay. Question number 5. How do you prepare for pregnancy? What is the best way to think about preparing for pregnancy with regard to nutrition and lifestyle? Because this is a big question people wonder about.
There's also this kind of overarching question, like, what can I do to affect my egg quality?
Yes.
Right? And I think we've all watched the news about highly processed foods affecting our lifespan and things like that. Remember, the eggs that somebody is going to ovulate go through a development cycle of about 3 months prior to ovulation. Lifestyle choices, including, we know smoking anything creates high reactive oxygen species, maybe puts other toxins in the environment and is going to damage an egg pool or somebody's ovarian reserve. Too much alcohol is at risk. There's a whole group of supplements out there that most of them do no harm, and probably most of them do no benefit. So I want to be careful out there for everybody who's on Google all the time and should I take this and should I take that? What's in the literature for people with diminished ovarian reserve, concerns about egg quality, is that none of these add-ons have really clearly been shown to be a benefit. So I think people have to be careful about how much it costs, the stress of taking all these pills, the pill burden, and the risk of some side effects with some of these add-ons that people take.
Yes.
I love Eastern medicine. I also don't always know what's in these Chinese herb packets and how
Yes.
they've been tested for quality control and herbicides and pesticides, things like that. So we want to be careful about that. So I think, your lifestyle does affect your likelihood for a healthy pregnancy and you being a healthy person, and you having good resilience to stress. So all those things kind of roll in. I mean, as a mental health professional, that somebody who has fertility challenges, that's the same stress as somebody has a cancer sometimes. So we want
Yes.
to take a good stock of what we can change. So try to have a regularly move your body, eat healthily, or look at toxins that you may be putting into your body, and think of things that you can do to structure your life in preparation for pregnancy, which is pregnancy is a lot of work for a human to take an embryo from this big to a baby this big. So that's going to involve adequate amounts of iron, calcium, B vitamins. So preconception vitamins I think are important. All these things roll in. As far as egg quality is concerned, there may be very little we can do to adjust that. Its age is the single greatest predictor for outcome. So don't forget your biological clock. And
Yes.
I think that if you're in your late 20s and early 30s, and you have the capacity, thinking about maybe freezing your eggs so you have your kind of a backup plan for your future, and understand that your reproductive autonomy is important. Like those are your eggs; they're not linked to another person, and they're not embryos and things like that. So protecting your fertility from toxins, working towards your healthiest weight and lifestyle, all those things are positive for egg quality. But we cannot back away from the kind of decline that's associated with age. That's probably the best thing you can do to protect your egg quality is either freeze your eggs at a younger age or get pregnant at a younger age.
Right. And even egg freezing is not a guarantee.
Yeah,
So,
absolutely. I do not call it an
yes.
insurance policy. I call it an assurance policy, a backup
Right.
plan. But you don't
Yeah.
know if it's going to work.
Right. So people really need to think about that if they're going down this road of using Chinese medicine or some other herbal supplements, and thinking about that they're also watching the clock.
Yeah, no, I do see some patients that have, for lack of finding the right word, they've kind of stalled for maybe 2 years. And those are two important years, maybe from 35 to 37, and
Yes.
attempting pregnancy and doing all these other things. And I wish they had come sooner.
Yes.
So, if you're attempting pregnancy and you're over 35 and you've been trying for more than 6 months, you need to figure out what's going on. Remember,
Yes.
40% of fertility challenges are male factor, right?
Mm-hmm.
As well,
Mm-hmm.
right? So in the world of donor conception, we're not usually talking about that, but I think that's important to know.
Yes, absolutely. Great advice. That's great advice. Okay. So those are my questions. What questions do you have for me, Dr. Landaris?
I have a lot of questions,
Okay.
and I think that the question that I, on the clinician side, struggle with sometimes is when to make that step. How does somebody know that donor conception is right for them? And it is something that, as a provider, sometimes I struggle to bring up, right?
Mm,
And I don't know how it's going to be received.
that's so tough. I certainly don't envy you for that. That is really tough. And I think for a lot of patients who are out there, they hear all of this information on the internet about being able to maintain their egg quality for a long time. And they say, well, my doctor said she got my best friend pregnant at the age of 45, and they don't know that this patient actually used an egg donor. And so this poor doctor is in this tough situation. So I certainly empathize with your position. And I feel like for everyone out there, this is a tough situation and everybody's different. We talked in our book about examples of people who've had very different experiences, right? So we mentioned a woman who said, if I had to bake a cake from a mix, or if I had to bake it from scratch, it'll come out the same. And I'm ready to just go ahead and be a mom. The cake is a cake no matter what. And then I also worked with a patient who had a lot of difficulty. She couldn't decide to do it. She couldn't decide on a donor. When she finally got pregnant, she struggled through her whole pregnancy. And after she gave birth, she had to rename her child to feel some sense of ownership over her role as a mother. So those are two extremes, and lots of people fall somewhere in the middle. but it's not right for everyone. Some people
Yeah.
want to be parents more than they want to have a genetic tie, and some people don't. And everyone needs to decide what's right for them. And if they and their partner, if they have one, have difficulty making that decision, I think it's good to talk this through with a couples therapist, because this is a lifetime decision. And as you're mentioning, your eggs are just going to get older. So it's not a decision that you can unwind easily down the road, right? We all get older and we have really a lot of things to consider in this moment that we have to take seriously. So everyone needs to appreciate that everyone's path is different. Your mother-in-law can't make that decision for you. Your best friend can't make that decision. Your sister may feel differently than you would. You need to do what's right for you.
Then there is a natural pull in most people for a genetic connection. And understanding that there might be some grieving to go on
Yes.
first before people can make that decision.
Yes. But some people really grieve, and some people say, okay, I feel sad about that, but it's okay for me to do, right? We did some research together, you and I, talking about same sex female couples, and some of them felt if they carried the pregnancy, that would be great for them. They didn't need to have the genetic connection. And some other women said that they really wanted that genetic connection. So I think some people feel much more strongly than others, and everyone really needs to appreciate what's right for them. And it doesn't make them wrong because they say, you know what, I'd rather be child free. Lots of people are choosing that path now because there's less shame about it, I think. So if it's not right for you, you certainly shouldn't feel pressured by your mother or your mother-in-law or whoever it is. And we're seeing all kinds of families built in lots of different ways, right? We talk about lots of families who are doing these collaborative relationships where people could be uncles or aunts to their recipients, where they have all different sorts of relationships, and there are different roles that they can play that may have not previously been considered years ago, but now they can play different roles in this child's life, and maybe that's what's right for them. So everyone really needs to make a decision that's right for them.
And I think you mentioned, getting access to experienced support. Question number 2, big one. Will my child, be upset about being donor conceived? How are they going to look at me?
That's a tough one. A lot of people
Thumbs
get
up,
upset.
though.
Yes, all the time. And I often say, if you have 3 kids in a family, and you and I both know this, we have kids who have very different personalities, right? You have 3 kids in a family, and the parent says it's time to go to bed. Kid number 1 says okay. Kid number 2 says, I can't believe my parents hate me so much, they make me go to bed early, they're terrible people. And kid number 3 says, my parents love me so much, they really care about my sleep, they really want me to be healthy. So we could have 3 kids in a family who all react differently, right? And so we don't know how our children are going to react. What we do have control over is how we behave with our children. And so what we can do is set them up for success in the best way possible. And that is to talk to them about their origins early and often, because the research does show, as it did with adoption, that people who find out accidentally or late in life seem to have the most difficulty. Will your child be in that group? I don't know. On this podcast, we've interviewed some people who found out late in life and they have beautiful relationships with their parents anyway. So we don't know. But what we can do is really try to stack the odds in our favor to have the best relationship possible with our children by communicating with them openly and early and honestly.
Yeah. So obviously, you were the person that came up with the idea, and I partnered with you willingly on it. But how do I choose the donor that's right for me? I mean, you've now committed so much time to this, as you put it through your present lens, having written the book and run the podcast and kind of become more of a outspoken personality on this. How would you answer that question now, different than, let's say, you would have answered it 10 years ago?
Yeah. So, and I really appreciate your partnership, Dr. Landeris. It's been so wonderful working with you on this. And I think you and I have both worked together so closely and seen so many of these cases where patients come to us so stressed because they just don't know what to do. They're looking at this array of faces and narratives about their donors, and they just don't know how to pick it apart. Should I pick the Tom Cruise lookalike? Should I pick the donor who's got the perfect SAT scores? Should I pick the donor who has the Italian background like I do? It's so difficult. And so people reflexively will choose a donor that feels good to them. And as we know, that doesn't necessarily set us up for the best chances for success, because ultimately everybody wants a happy baby, right? Everybody says in the end, their baby's cute. Their baby's sweet. Their baby is the best baby in the world, but we want our child to be healthy, and we want our child to be healthy for the long term. And so we outline in our book, and there's really too many details to discuss in this podcast, but that we really try to flip the script and think first about how we're going to give ourselves the best chance that we're going to have a healthy donor. So just to narrow the pool and make it easier, we need to first think about psychological screening. You need to make sure that you have appropriate psychological screening. And we have a podcast episode just on psychological screening. So you can look at that with one of the creators of the personality assessment inventory. And then we need to think about genetics and how it's going to influence the future child. And people very often say, well, my donor is healthy. Well, chances are they are healthy, right? They're healthy people, they're young people. But are there other issues in their family? Not just issues that the geneticist is going to discover in your genetic counseling appointment, but also in their history with their parents, with other members of their family, because you are not choosing just that person. You're choosing their gene pool, right? And then after that, we need to think about things like, is this donor going to be open or not? And we have many more options for openness. I do recommend that if you can contact your donor directly rather than just through the agency, it's much better. We don't know in 20 years from now if the agencies or clinics are going to be around. And if you establish, right, your own relationship, then you can have ownership over that relationship and not worry about struggling to contact that donor. So many people struggle to contact their donor, either for medical reasons or for social reasons. So even if you don't think that you're going to have a relationship with your donor, it's really important to start that contact process now, so you have that opportunity. And chances are, as you develop in your role as a parent, as you feel more comfortable with your role as a parent, you'll be more interested in talking to your donor because it will feel less threatening. So it is really important to think about that now. Give yourself those opportunities, keep those doors open for you. And then last, everything else is gravy. If you want someone because you think that they have the same laugh as you, or because they have the same cultural background or the same value system, that's great. But those things are not necessarily heritable. 3 kids in a family, as I said before, are all different, right? And you're not choosing that person. You're going to get the mother's dimples, the father's sense of humor, and, the grandfather's cleft chin. So you really think wisely about what you do have control over more than what you don't have control over.
Perfect. Well, that really dovetails or segues right into the next common question, which is an anxiety driven question, I believe. How do I prevent my child from having donor related siblings? So
Well,
people worry about that.
yes, people worry about it. And I think it's really important to clear this up. And by the way, if anyone is curious about more information about choosing a donor or wants to dig deeper into the subject or any of the subjects we're discussing, please look at our book. We outline all of these subjects in detail. So if you want more information or you leave this podcast with questions, please take a look at our book. And of course, certainly reach out to us. Yes, there it is. I really think this is important because, yes, you can create a contract with your attorney or with your agency that says, I'm allowed to reach out to my donor when my child's 18, or I can contact my donor for medical reasons, or under these circumstances. However, there is no contract right now that's enforceable. Hopefully, your donor will be honest and will honor their agreement that they're only going to donate X amount of times if that's what you'd like. But there's no way to enforce it. And you remember, these people are young people, right? They're in their young 20s, and I know when I was that age, I wanted to travel the world and do all kinds of things, they may change their mind. They may meet a friend who they want to donate to. They may meet somebody else they want to donate to. So we don't know. I do think if you meet your donor, you have a much better chance of this happening, because I do think that people who see the people whose lives they're changing, and Dr. Leondaris and I created an open donor program at Illum Fertility, and it's a beautiful program, really the only program of its kind on the East Coast. And we saw year after year that these donors were really happy to meet the recipients. And once they met them, they said, this is a different experience for me. This is not just a medical experience. Now I'm seeing the faces of these people whose lives I'm changing, and it feels so differently. And I think if your donor feels that way about you, if you make that face-to-face connection, there's a much bigger chance that they're going to honor their agreement. They're going to feel much more committed to you. And so if you feel that you have the stomach for it, and not everybody does, because someone who just went through infertility treatment may still be grieving. It may be hard to do that right away. But if you're able to contact your donor, I think it will pay in dividends later for you, because you will have so many more opportunities in your future to contact your donor, and possibly even to limit siblings.
You could speak about this a little bit more, but there's no real way to prevent your child from having donor-related siblings, because there's a pretty good possibility that your donor is going to want to have their own children anyway.
Yes.
They might donate 2 or 3 other times.
Mm-hmm.
If it's an egg donor or if it's a sperm donor, that's really the concern for a lot of people that are there like 50 or 60 have
Yes.
siblings out there. And we talk about this in the book extensively. I think that you have more experience than most in connecting donor related siblings, and speaking to that a little bit. Most of the children that are connected, or young adults that are connected, are somewhat happy about having donor related siblings. Is that
Yes,
the general
absolutely.
rule?
Yes. Yes. It's particularly what we're finding in this early research is that people who are single children are very excited about it, because these are the siblings that they would have otherwise never
Yeah.
had. And so they're very happy to connect. But lots of people are interested in meeting donor related siblings, number one. And number two, they're also interested in meeting other people who are donor conceived, because
Yeah.
usually in their classroom or with their parents, they don't know other people who are donor conceived. And
Yeah.
so they also enjoy that. So there is some benefit to connecting with other donor conceived children at some point. And there is a lot of debate about whether or not to do it early. Some people feel that it's better to start early. Some people feel it's better just to let your children make that decision. So the jury's still out on that. But people do seem to feel very interested in meeting donor related siblings.
All right. The last question I have from you, from kind of the audience, is how do you choose an agency, either a surrogacy agency or an egg donor agency? There's so many of them out there. There's like 300 egg donor and surrogacy agencies each. So
Yes.
what's your advice on that?
I think it's so difficult, because what patients don't typically realize, I think you might agree with this, is that we have the Society for Assisted Reproductive Technology, where, for those of you who aren't aware of it, you can look at asrem.org or on the CDC website and take a look at your clinic and look at success rates. So it's possible for a layperson to look at success rates for their clinic. There is no such thing in agencies. It doesn't exist. There's no rating system. There might be Google reviews, but there is no rating system or quality control system. So what you're left with is looking at a website and getting Google reviews or looking at your friends' reviews. So it's a difficult process. I do think it's wise to talk to your doctor, not just about, who they worked with, but who they've had good experiences with. It's a good idea to talk to friends who've had good experiences. And I think most of all, it's good to try to remember you're looking with a gestational carrier for a good gestational carrier. Lots of people think, I only want to have a gestational carrier who lives in the same town as me, so I don't have to travel that far. Well, all things being equal, that would be great. But all things are not equal. You may not have the superstar surrogate in your town. She may be, on the other side of the country, and it's worth a few plane flights to see her if she's going to be the best surrogate for you. With donors, you're not really looking at who's going to carry for you. You're looking at genetics. So again, we really want to think about who's going to give you the best possible chance for a healthy child, and then also potentially some openness. So both of those things are really important. There are small agencies, medium-sized agencies, and large agencies. And all three of them give you different levels of handholding and different levels of costs. So you really need to think about the level of costs and handholding that you need, and that's individual to every single person. And then last, I will say, as I've said earlier, it's really important for different reasons, obviously with the surrogate than the donor, but to have psychological screening that follows the guidelines from the American Society for Reproductive Medicine, because those screening tools are really, really helpful in not just assessing psychopathology for the donor, assessing their readiness to donate, assessing their ability to manage the process. But for gestational carriers, you want the same sort of thing. You want to make sure that they're going to carry a healthy baby, that they want to do this for good reasons, that they are the sort of person that you're seeing in your match meeting. So I think it's very, very important to make sure that those assessments are completed by a seasoned professional who is active in the ASRM, not just someone who pays their dues, but somebody who's involved, goes to meetings, and has continuing education.
So you want to interview probably more than one donor agency or surrogacy agency and ask them some questions on their experience, their own kind of training. And I think it's hard. It's hard to choose a surrogacy agency or donor agency, but I will also say, and I think you will agree with me, most of the people in this field are really focused on shared success with their clients. So we all kind of are on the same page.
Yes.
I think that's important. You want to be pregnant, your agency wants you to be pregnant as well. And the donor that donated wants you to be pregnant as well. All one big positive.
Yes.
So I think you covered my 5, and this was so wonderful to get a chance to chat. I hope this was helpful for everybody out there.
Yes, this is wonderful. Thank you so much, Dr. Landeros. I hope that everyone feels that their questions have been answered. And certainly, if you haven't, you can reach out to us anytime. Where can people reach you, Dr. Landeros?
You can reach me through Illume Fertility. It's just mleanderis at illumefertility.com. If you don't hear from me the first time, ping me again, though.
Okay. Or you can ping me and I will get to him for sure. But take a look at our book, Building Your Family, because there's lots of information that's really helpful. And certainly come back to this podcast anytime. We have lots of information to share. Follow us on social media. Email me at familybuilding.net at any point and join my newsletter so you can stay active and get all the newest information. And please come back, subscribe, because that's how we keep going. So I hope this was helpful. And thank you so much for coming.
Thanks, Lisa. Thanks, everybody.
Hi, it's Lisa Schumann. I hope that you enjoyed that video and I hope it helped you. And if it did, please give us a thumbs up and subscribe because that's how we keep going. It's really important to us. And if you liked it, you might like this one.